med.com. Welcome to another MedCram video. Today we're going to talk about how Hantaviruses actually kill. And I want to be specific here. There's two types of Hantavirus. There's those in North and South America, which is what is in the news lately. And there's also the old W world Hantaviruses, which are in Europe and Asia. We're not going to be talking about those. Those particularly hit the kidneys and the mortality rates are lower, like 1 to 15%. Today we're going to talk about North and South America, and specifically the Andes type of Hantavirus, which has a much higher lethality or mortality rate, about 40%. And we're going to talk about the syndrome that is associated with that, which is cardiopulmonary, and why this seems to do so poorly, and why people need intensive care services when they get this. So let's get started. And what I'm drawing here is a lung alveolus. So this is where gas exchange occurs. And what we have here is the pulmonary artery. And there are deoxygenated red blood cells that are coming towards the interface between the pulmonary vascule and the alveoli, or the air pockets. Then we get oxygen, which is here, and it's going to diffuse into that capillary where it's very thin, and it's going to cause oxygenation of the red blood cells into the pulmonary vein. So this is the key to understand, is that there are large numbers of these units where oxygen is coming in and carbon dioxide is being let off. And this is where gas exchange is occurring. So oxygen is going in, carbon dioxide is coming out. And the key here to understand is that there are cells. These are the cells right here that line this vascule. And these are known as endothelial cells. And they are very thin. And they need to be very thin because you need to have these gases be able to go through these compartments, the alveolar compartment and the intravascular compartment, and allow for exchange. If these things become damaged or it becomes thicker, you're not going to be able to get the same type of gas exchange. So what we see happening here is the virus, which I'll have here in green, comes into the alveolar space. Now, this can happen because the viruses are in the mouse droppings, or they're in the mouse urine, or in the mouse saliva. And if they get stirred up because someone is sweeping, or because someone is vacuuming and they're not wearing the appropriate mask and protection, they could inhale these viral particles. And then these viral particles will infect, and they'll go through, and they specifically like to infect these endothelial cells. And because they're being inhaled, this is the vascule that they infect, the pulmonary vasculature. And to make a long story short, which we'll go into, essentially what happens is that when they infect these endothelial cells, this infection can go on for days if it's not taken care of by the innate immune system, which includes interferon. We've talked about this before, but what these viral particles do is it suppresses the body's ability to make interferon. That's why this thing goes on for such a long time. These symptoms can go on for days before the ultimate collapse occurs. And what causes the ultimate collapse and ends up killing the patient is that these endothelial cells, which should have very tight junctions between them, these junctions have to be very tight because all of this plasma, all of this black stuff in here inside the intravascular space is fluid. If these junctions weren't tight, then what would happen is that the plasma would leak from the vascular space into the space where the air is supposed to be. And that's exactly what happens in this situation, is that these tight junctions become very leaky. And this area here fills up with fluids, and sometimes the junctions can become so leaky that in fact red blood cells get in here, and the patient's lungs essentially fill up with blood. Now you can see that there's two problems you're seeing here. The first problem is in this space here, that it should be dry and it's becoming wet. And that's a problem because you cannot have good gas exchange. The other thing that you'll see here is that all of the fluid that's in here in the vascule you're pumping around your body should be very wet. A lot of fluid, and it's becoming very dry. And so what happens is you become in hypovolemic shock, or you have less volume in your vascule, and your organs don't get enough perfusion. So you start to go into failure because not enough blood is circulating around, and your lungs start to fill up with fluid. You don't get enough oxygen. And you can see that that's a real problem. And the epicenter of all of this are the tight junctions that we see in these endothelial cells. You should have a nice tight junction. We'll use red here again since we used red before. So here's the red endothelial cells, and they're very tight junctions, so that when you have fluid on this side, it can't get into this airspace. But when the viral infection comes, what that turns into is something like this. It becomes leaky. And so what happens is fluid is able to leak from one place to another, and that's making this area dry and this area wet, and that's exactly the wrong thing to have. Of course, what happens is that this inflammation can also cause problems with the heart. You can get arrhythmias, and it's likely the reason why people just all of a sudden collapse. They have low oxygen. They are in shock. They can't breathe. They're trying to breathe, which requires more pumping from the heart until finally the body just cannot give anymore. So let's go through this again in stages. Exposure is the first phase, and that's going to happen when you have fevers, fatigue, myalgias, headaches, chills, dizziness, abdominal pain, nausea, vomiting, diarrhea. It doesn't look like a pulmonary disaster. It just looks like a regular flu type of virus. And that goes on for 4 to 10 days. This is the magic window where you can actually do something about it. If you can improve the innate immune system, if you can improve interferon, we talked about hot and cold as a potential intervention. We've talked about the role of interferon. It's this first area here where you have exposure, and then it goes, as we mentioned, to the early phase. That's where you have this flu-L-like feeling. Then you go to stage 3 where you have the endothelial phase. That's when it infects the endothelium, as we talked about here. Phase 4 is where you get leaky pipe, and the infected endothelium becomes abnormally permeable. And there's several overlapping mechanisms that have been proposed there as to how that works. For you want to get technical, there's something called VEGF sensitization, where you have pathogenic viruses can make endothelial cells more responsive to VEGF, which is a messenger and a permeability promoting factor. They talk about increased VEGF signaling and degradation or disruption of the endothelial junction controls, including some related mechanisms associated with that. There's also something called beta-3 integrin. They'll talk about that in the literature. Can viruses use endothelial receptors, including beta-3 integrin and protocaterin 1, signaling for attachment and entry? And the infection can dysregulate non-lytic endothelial barrier function. That's another one there. We'll talk about the proteins on the surface of the endothelial cells here in just a second. There's other immune amplifications that are here called CD8s, and these are a type of T cells. The CD8 T cell responses and inflammatory mediators may contribute as well. Has specific T cell responses in the pulmonary cardio version of Hantavirus have actually correlated with disease severity, suggesting that immunopathology is part of the injury. Then there's also another one called bradykinin pathways that's been implemented. And I'm bringing up all these things here now because I'm going to test you at the end. But these are areas of research that people are looking into to see if they can modulate this so that you don't get this problem where the things that are dry become wet. The things that are wet become dry because that is the problem. So the bottom line here is that Hantavirus turns a normally tight capillary bed into a sieve, not necessarily by ripping the vessel apart, but by changing the signaling that keeps the barrier sealed. This is sometimes supposed to be leaky, so you can have inflammation fix things. But what Hantavirus does is it abnormally makes it leaky, and then you have a real problem. What happens clinically is you'll see this on a chest x-ray. Looks like this. This is the heart. You'll start to get bilateral pulmonary infiltrates in the middle. We call that non-cardiogenic pulmonary edema. And this is very similar to what we saw with CO-19, because you have fluid where fluid should not be. That non-cardiogenic pulmonary edema simply means that fluid is being backed up into the alveolus here, and it's filling up with fluid. And it's not because of the fact that the heart, which sits over here, isn't pumping forward and things are backing up and causing pressure to push this stuff into the alveolus. It's not because of that. It's simply because these capillaries here are so leaky that the fluid is just leaking out and filling up these alveoli so you can't breathe. So as we talked about, when this fluid is all leaking out, the amount of fluid that's left in the vascule starts to drop. And as a result, the heart, it doesn't get enough perfusion, the heart starts to fail. You get increased pulmonary vascular permeability, extravascular lung water, hypoalmia, reduced stroke volume, myoardial dysfunction, and then finally circulatory impairment. The bottom line here is that the lungs are wet and the circulation is dry, and that's what leads to death. So obviously, if you're in the intensive care unit, you can actually hydrate people, monitor them. You have to be careful, of course, because if you give too much fluid here in the intravascular space, it could flood this space even more. This is why intubation is so key in these types of patients, because when you intubate somebody and put them on a ventilator, you're actually pushing air down into the alveolus, and you're pushing this fluid back out into the vascule. And that's important because then you can start to dry out these alveoli and push the fluid back into the intravascular space. And you can support these people long enough so that they can actually improve and get better. And they are even able to do ECMO. ECMO is a way of basically bypassing the lungs and oxygenating the blood so that the patient's lungs can get better on their own and the patient doesn't die in the process. So ECMO has actually dramatically improved survival in patients with high virus. The problem is that there's just not enough ECMO centers to treat everybody that you have in an outbreak. So if you look at the data, the CDC says that HPS or HNTA pulmonary syndrome is fatal in about 4 out of 10 infected patients. Of course, that number goes down if you have ECMO, if you have support, ICU. The technical number that they use is 38% mortality among people who develop the respiratory symptoms. So that's why early ICU admission is so key after you have exposure, the early phase where you feel like you've got the flu. Number 3, after you have endothelial damage. Number 4, after the leaky pipe. Now you're getting into like the pulmonary edema, which is number 5, right there. And then number 6 is where you have depletion of the intravascular space. And then finally, number 7 is where your heart fails and you basically collapse. Now, I wanted to just give you a little bit of education in terms of the proteins. Here is our virus. This is our Hantavirus, and it is going to bond to this endothelial cell right here. We've talked about the spike protein of SARS-CoV-2, and we've talked about the A2 receptor on the surface of the cell. There's something similar going on here, and I'll tell you what those names are here for this Hantavirus. And since we're talking about a specific type of Hantavirus called the Andes, I will be specific to the Andes virus. It's the Andes Hantavirus. And specifically, what we're looking at here is a protein on the surface of that virus called the GN, or the GC protein. So GNGC is the protein on the surface of the Andes Hantavirus. And what does it bind to? There's 2 types of proteins or receptors on the surface of this endothelial cell. One of them is called protocaterin 1. The abbreviation for that, since it's such a long word, is PCDH1, and that's what we see in the Andes virus, and the one in North America called the Synobi virus. But if you're looking at the older pathogenic literature on this, the one that they have identified on there as well is the B3 integrants or the beta 3 integrants. And notice we talked about that down here, as with the leakiness, and that's what may be going on. So for this type of antivirus, the Andes, think of G and GC, which is on the virus side, and think of the protocaterin 1 protein on the surface of the endothelial cell. So, but what does this all mean? This is the sort of slow-motion rolling disaster that happens in people who get infected. What the virus does in the early phase here is it tries to suppress interferon so it can burn along as long as it can and infect as many cells as it can. The more endothelial cells that it infects, by the time it gets to the endothelial phase and the leaky pipe phase, there's much more leaking going on. The people that survive Hantavirus are those that mount an interferon response, which is so robust that it's able to limit the number of endothelial cells that get infected, so that when the leaky pipe phase occurs, there's much less fluid and there's much less shock. So, what's the key here? The key here is getting early treatment, and the key is limiting the amount of endothelial cells that gets infected. And I've said this before and I'll say this again. I think the key here is knocking out the virus's ability to suppress your own body's ability to make its interferon. And we've talked about one of the things that can do that, which is making sure that there is elevated temperature. But that needs to be done in a judicious way. We'll also talk about in future videos some of the trials going on looking at antivirals, but again, that needs to be done early. There's no distinction here in the early phase that tells you have antivirus. You just feel bad. You have all of the symptoms of a viral infection. It's not until you get to the leaky pipe phase after your endothelial cells have been infected that it's getting too late and you need to make sure that you show up to an intensive care unit so that they can manage the alveoli, making sure that they don't get flooded, and making sure you're getting enough aggressive IV fluid hydration so that you don't go into cardiovascular collapse and have cardiac arrest. So, this is how antivirus kills. Knowledge is power. If we know how to break this chain, we can improve survival in patients who have Hantavirus. If you enjoyed this video, subscribe, leave us a comment, tell us how we can improve. Join us at medcram.com. This is where we have continuing medical education videos for healthcare providers. This is how we support this channel. Notice that you don't have to pay for any of this. It's free and I enjoy doing it. I want to make sure that everyone gets educated on exactly what's going on. So, thank you for joining us. See you next time.